A very good morning to all our honorable speakers and our dear colleagues. So, on behalf of the Emergency Medicine Faculty of Hospital Chancellor Tuan Murais, it's my great pleasure to welcome everyone to the second week of our 8th Emergency Medicine Seminar Series. My name is Dr. Baradan and I will be your moderator for today's program. The 8th Emergency Medicine Seminar Series is proudly organized by University Kebangsaan Malaysia, University Brawijaya, and the University of Philippines. So, without further ado, I would like to invite our first speaker. It is my pleasure to introduce our first speaker for today, Dr. Mohammad Akmal Omar. Dr. Akmal is currently pursuing his Doctor of Medicine in Emergency Medicine at University Kebangsaan Malaysia. He has extensive clinical experience as a medical officer at Hospital Teluk Intan, Hospital Sungai Buloh, and currently at Hospital Chancellor Tuanku Muhammad. His clinical interests and experience include trauma and medical resuscitation, pediatric resuscitation, critical care, and point of care ultrasound. With his experience in managing critically ill and his ongoing postgraduate training in emergency medicine, we are certainly looking forward to gaining valuable insight from him today. Today, he will be sharing with us on the topic with the title of Association between Rate of Proximal Progression with Antivenom Administration in Naja Species Bites Management in Malaysia. Without further ado, please join me in welcoming Dr. Mohammad Akmal Omar.
Okay, thank you, Dr. Bharathan, for that introduction. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. Okay, all right. So, first of all, I declare there's no conflict of interest. So this is going to be the overview of my presentation today. So we're going to go a bit on the background of the subject at hand. And then I'm going to proceed with the study objectives, the research questions, the methodology, results, discussion, conclusion, and some key take-home messages. All right. So regarding snakebite in Southeast Asia, so it is already known that snakebite is a neglected public health issue in many tropical and subtropical countries. So in Asia, up to 2 million people are envenomed by snakes each year, which is acknowledged by the World Health Organization on snakebite envenoming. So in Southeast Asia, it is estimated we have about 242,000 cases of snakebite victims per year. It is estimated that there is about 15,000 deaths which occur every year in the Southeast Asian region due to snakebite-related injuries. This includes about 950 amputations per year, and not to mention about 390,000 years of life lost and 800 years lived with disabilities. So snakebite confers significant morbidity and mortality, and also the significant economic burden to the healthcare and non-healthcare-related costs, because it is estimated that the region loses about $2.4 billion per year due to snakebite-related costs. So regarding cobra bites in Malaysia, cobras are common causes of snake-related injuries in Malaysia. And endemic to Malaysia, we have Naja Kauthia and Naja sumatrana. So Naja Kauthia is monocoque cobra, which is mainly found in northern, central, and east coast region of peninsular Malaysia. And Naja sumatrana, which is the equatorial spitting cobra, which is found throughout Peninsula and East Malaysia. So these cobras possess potent postsynaptic neurotoxic, cytotoxic, and cardiotoxic venom. So, and bites from these cobras may lead to severe envenomation that can cause permanent disability or death. So bites from cobras may cause local or systemic envenoming. So local envenomation symptoms and signs include pain, progressive edema, and tissue necrosis. Whereas systemic envenomation, signs and symptoms include ptosis, ophthalmoplegia, dysphagia, and skeletal muscle paralysis. So unique to Naja sumatrana, they may incur venom ophthalmia, which is the spraying of venom from the cobra, which causes hyperemia, uveitis, and corneal erosion. And bites from these snakes may cause respiratory failure, which may require intubation. And some patients even come in cardiac arrest. Now, antivenom is the primary treatment and the only specific treatment for snake envenomation, according to the World Health Organization. So antivenom is immunoglobulins, which are purified from plasma of animals that has been immunized with one or more species of snake. So these immunoglobulins bind to venom toxins and forms complexes, which renders the toxins inactive and improve elimination. So in the management of cobra bites in Malaysia, we have two main antivenom that we use. So we have monovalent antivenom and we have polyvalent antivenom. So the monovalent antivenom is the QSMI cobra antivenom, which is used for Naja species. And then we also have polyvalent antivenom, which is the QSMI, neuropolyvalent snake antivenom, which may be used also for cobra envenomation. So both of these antivenom are sourced from Thailand. Malaysia, we don't produce our own antivenom. Now, the decision to administer antivenom relies on subjective visual estimates of local envenomation and the presence of systemic signs. So, in the past, criteria such as swelling involving more than half of the bitten limb, swelling of the digits, and rapid extension beyond the joint have been used to indicate the need for antivenom therapy. The problem is these criteria are often subject to significant variability between clinicians and cannot be used to monitor for treatment response or failure. They are very highly subjective. So in Malaysia, we have utilized something called the rate of proximal progression, or RPP. So RPP have been utilized in the management of venomous snake bites in Malaysia to guide healthcare providers in the initiation of antivenom and post-treatment monitoring. So what is RPP? So RPP is a trend-based parameter that we objectively measure the progression of local envenomation at fixed time intervals and is reported in centimeters per hour. So an accelerating RPP trend may indicate the need for antivenom, while a decelerating trend post-antivenom therapy may indicate success. So RPP can be used to prevent unnecessary administration of antivenom and ultimately reduce the risk of adverse effects and preserving resources. Now, a little bit of regarding REX, or Remote Envenomation Consultancy Service. It was established in 2012 by a group of emergency physicians with special interest in clinical toxinology and members of the MST. So REX provide consultation service to healthcare providers of various backgrounds in the diagnosis and management of snakebite cases through snake identification and advocacy of appropriate treatment modality. So analysis of the REX database have provided valuable insight to snakebite management of various various snake species in Malaysia. So my study, the objective was to investigate the association between the rate of proximal progression with antivenom administration for Naja species bites in Malaysia consulted to REX. Okay. Now, so in conclusion, why did we do this study? What was the relevance? So we know that cobra bite leads to severe envenomation. And antivenom is crucial to reduce morbidity and mortality in these patients. Unfortunately, the previous traditional criteria for antivenom in local envenomation was highly suggestive. So we utilize RPP. So RPP is potentially useful, but it is yet to be validated. Now, the study objective was to determine if there is a positive association between an accelerating RPP with antivenom administration in Naja bites. And number two, to determine if there is a positive association between accelerating RPP with intubation. Number three is to investigate if antivenom administration decelerates the RPP. And number four, to investigate if there is a positive association between a non-decelerating RPP with a second dose of antivenom administration in cobra bites. So what are the questions that this study wishes to address? Does accelerating RPP, pre-antivenom RPP, is there an association between accelerating pre-antivenom RPP with antivenom administration? Is there an association between accelerating pre-antivenom RPP with intubation? Does antivenom administration decelerates the post-antivenom RPP? And is there an association between a non-decelerating post-antivenom RPP with a second antivenom dose administration? So this was a retrospective cross-sectional study. We utilized convenience sampling to select cases that fulfills the inclusion criteria. This includes confirmed Naja Species Bites consulted to the remote envenomation consultancy services, and information of baseline demographics such as age, gender, nationality, ethnicity, and presence of comorbidity. The presence of local and systemic envenomation symptoms and signs were collected. Now, our primary independent variables were pre-antivenom RPP, pre-antivenom PSP, and post-antivenom RPP. So now what is pre-antivenom RPP? So pre-antivenom RPP is defined as the RPP trend upon patient's arrival to the hospital up to 6 initial readings prior to the first antivenom dose administration. So for example, when the patient comes to the hospital, you initiate your RPP and then you measure the RPP consecutively. So now, if the RPP is accelerating, for example, the first hour you measure it's 1 centimeter per hour. The second hour you measure it's 2 centimeters per hour, and the third you measure it's 3 centimeters per hour. So this is accelerating. So 3 consecutive RPP showing increasing amount in centimeters per hour. So this is accelerating pre-antivenom RPP. Whereas pre-antivenom PSP is defined as pain score reported by patient upon arrival to hospital and up to 6 initial readings prior to first antivenom dose administration. For example, we use the pain scale of the WHO pain scale, so 0 to 10. If the patient initially reported pain score of 6, and then the next hour reported a pain score of 7, and then in the third hour reported a pain score of 9. So this is an increasing pre-antivenom pain score. So these are all documented, and then we collected these data for our analysis. Now, post-antivenom RPP is defined as the RPP trend after completion of the first antivenom dose administration. So the most important is to see whether the post-antivenom RPP decelerates or not. So what does decelerating post-antivenom RPP means? So for example, you've administered the first dose of antivenom, and then you measure the RPP post-antivenom. So if the post-antivenom RPP shows initially from 2 and then goes to 1 centimeter per hour and then goes to 0.5. So this means the RPP is decelerating. Okay. So these are the independent variables that we collected. So what are the dependent variables? So dependent variables includes the initial antivenom dose administration, intubation, and second antivenom dose administration. And then we evaluated the data for normality distribution using Kolmogorov-Smirnov, and categorical data were reported in frequencies and percentages, and data analysis was performed using SPSS version 30, and we used the Fisher's exact tests and univariate and multivariate logistic regression analysis. So now moving on to the results. As you can see, we recruited about 131 patients. So out of 131 patients, 40 patients received a first dose antivenom, while 91 did not. So the median age for those who received antivenom was 43 compared to those who did not receive antivenom was 26. So those who received antivenom was slightly older. And predominantly in both groups, the male was the predominant gender, and Malaysians make up the majority of patients who were included in the study. All right. So now if you look at the data, if you look at the comorbidity, we have 18 patients in total who were included in the study. Up to 50% of patients with comorbidities receive antivenom. This I will explain later. Why is this maybe such, right? Otherwise, other demographics such as the cobra species and bitten part were not that significant. In regards to the local and systemic envenomation signs and symptoms, if you look at it, basically 100% of patients who have had antivenom administered reported pain. So that's pretty logical. And 95% of them were experiencing edema, and 47.5% had dermonecrosis. Whereas in terms of systemic envenomation, GI symptoms, which includes nausea and vomiting and abdominal pain, were reported in up to 45% of patients who've had antivenom administered. Now, if you look at the table below, those who've had antivenom administered, 40% of them reported increasing pain scores. 42%, 42.5 reported pain score that was static. And then in terms of pre-antivenom RPP, 70% of patients who received antivenom reported an accelerating pre-antivenom RPP. Okay, so just from the raw data, you can actually see that those who've had accelerating pre-antivenom RPP more likely to receive antivenom. Now, looking at the odds ratio or crude odds ratio for predictors of first antivenom dose administration. So this was a univariate logistic regression analysis. We included all the baseline characteristics. And if you see here, there are a few that stands out, right? So for example, in those who've had pre-antivenom RPP trend who's accelerating, the odds ratio of receiving a first antivenom dose was 28, which is significant. If you see the p-value is less than 0.01, so statistically significant. Other than that, those who reported an increasing pain score had a whopping 166 odds ratio of receiving a first dose antivenom, which makes sense as well. If those who reported pain, significant pain, and the pain is increasing, that means it's more likely for them to receive antivenom. And in patients who've had comorbidities, the odds ratio was 2.6, but the p-value was 0.06. So just shy of a statistically significant result. But later on, we will see if the presence of comorbidity will become significant or not when we do the multivariate logistic regression. So just a summary of this table, what you can see is that the predictors for first antivenom dose administration were significant for those who have accelerating pre-antivenom RPP and increasing pre-antivenom PSP or pain score, and then those with comorbidities. Now, for the association between RPP, pre-antivenom RPP with intubation, we did basically a chi-square test, and we saw that the odds ratio of those with accelerating pre-antivenom RPP were increased for intubation, so 5.75, but the p-value is 0.17, so it is not statistically significant. So, but we do see a signal of those with an accelerating pre-antivenom RPP to have intubation. Okay. Now, moving on to the association between post-antivenom RPP with a second antivenom dose administration. So the majority of patients, actually, you can see majority of patients who've had antivenom administered shows a decelerating post-antivenom RPP, which is 36 out of 40. And if you see the odds ratio, those who've had a non-decelerating post-antivenom RPP have a higher odds for a second antivenom dose with an odds ratio of 35 and p-value of 0.02. So this is statistically significant. So when a patient comes in and then they've had antivenom administered to them, those with a non-decelerating post-antivenom RPP had a higher odds to receive a second dose of antivenom. Now, we constructed a multivariate model to adjust for potential confounders. So we did a multivariate analysis for predictors of first antivenom dose administration. So when we adjusted for age, nationality, comorbidity, snake species, bitten part, and all the other variables, we can see that actually some of the results have changed. So if you see on the first one, those with comorbidities, the adjusted odds ratio increased. So to 9.19 with a p-value of 0.13013. So it became statistically significant. All right. Other than that, in patients with an accelerating pre-antivenom RPP, the odds ratio also increased to 42 when adjusted to other confounders with a p-value of 0.01. So it become more significant, right? Whereas those with increasing pre-antivenom pain score progression, the odds ratio reduced to 98, but still remains statistically significant. Okay, so let's move on to the discussion, right? So our data shows that both an accelerating rate of proximal progression and an increasing pain score progression, they are robust clinical indicators for antivenom initiation. So what does that mean? They are good predictors for initial antivenom administration. Let's start with accelerating pre-antivenom RPP. So we know that Malaysian cobras have potent cytotoxic components. So when these patients were bitten, once injected, the venom drains via the lymphatic system, and it propagates proximally. So if you see that the RPP is accelerating, this signifies that there is ongoing tissue injury that requires neutralization to mitigate further damage. Whereas in those with increasing pre-antivenom pain score progression, this also reflects significant local envenomation. Now, we know that the quantity of inflammatory mediators released is proportional to the volume of venom injected. So more volume of venom gets into the tissue, more inflammatory mediators are being released. And when there are more inflammatory mediators that is being released, more pain receptors are being stimulated, so and thus more pain. So these go in tandem, these go hand in hand. So when you have an accelerating pre-antivenom RPP, most of these patients also have an increasing pre-antivenom PSP. So it is very important for us to monitor these patients pre-antivenom so that we can catch these signals, okay? Now, for the other factors that were significant for an initial antivenom dose administration was the presence of comorbidities, okay? Conditions such as the presence of diabetes, hypertension, end-stage renal failure. Why do these patients show an increased odds to receive antivenom? So these patients have impaired physiology and impaired reserve. So they also, because of their pre-existing conditions, they have altered inflammatory response, which predispose them to complications. So in the study, it was shown that patients with comorbidities who were bitten with snakes, they have an increased risk for complications such as acute kidney injury. So it is very important when a patient comes to your department, you also need to know their background medical history, because these may trigger you to monitor them more closely compared to those without comorbidities, okay? Next is for the predictor of second antivenom dose administration. So it was found that non-decelerating post-antivenom RPP was highly associated with a second antivenom dose administration. Why is that? So a non-decelerating post-antivenom RPP reflects incomplete venom neutralization. So we know that the antivenom contains immunoglobulins, and these immunoglobulins will bind to the venom, which enhances elimination. But when you have a non-decelerating post-antivenom RPP, this suggests that the venom load exceeds the binding capacity of the antivenom. Thus, why these patients requires additional doses. Okay, so it is very important for us to monitor the post-antivenom RPP to see whether your treatment is effective or not. So if the patient has a decelerating post-antivenom RPP, this most likely reflects that the treatment is successful. Whereas when you have a non-decelerating post-antivenom RPP, this may suggest that the envenoming is ongoing and you may need to administer a second dose of antivenom. Now, for the predictor for intubation, we found out that the pre-antivenom RPP was associated with intubation, but did not reach statistical significance. So why is that? This is most likely due to the low frequency of cases which requires mechanical ventilation. So if you look at the previous table, all right, so there were only 3 patients who were intubated. So the amount of patients who require intubation that we collected for the study was small. So this may this is why maybe that the odds ratio, even though it was associated with it shows association but did not reach statistical significance. So but we know that the venom of the cobra venoms contains potent neurotoxin, and they causes postsynaptic neuromuscular junction blockade, and we know that a higher venom load confers a high degree of neurotoxicity. So we can say that the rapid progression of edema can be used as a surrogate for high systemic venom concentration, but we must always remain observant for systemic signs that may not be reflected on the local signs. Okay, so we must always look not just on the RPP, but also on the clinical signs on the patient, such as the presence of ptosis, shortness of breath, respiratory distress, and so on and so forth. Okay. So, moving beyond subjective assessment, while the World Health Organization emphasizes treating rapid local swelling, traditional assessments like I mentioned before was notoriously subjective. So, what our study suggests is that patients with an accelerating RBP is a better how can you say parameter to be used compared to just visual estimates, such as whether the swelling has crossed a joint or not. So it aligns with the WHO guidelines. So antivenom is indicated in patients with rapid extension of local swelling. But instead of just doing, guesswork, RPP provides a more detailed and quantitative alternative. Okay. And also, the good thing about RPP is that it standardizes our assessment. So it is a more precise way of monitoring pre and post treatment. And it also facilitates management between different healthcare centers. For example, if the patient was admitted to initially to hospital A, rather than using something that is subjective, you can use RPP. And because RPP is standardized, so when the patient is being transferred to hospital B, you know that the RPP is something that you can reproduce easily, and it is better for the patients and also the clinicians, because it makes our job much easier. Okay. So other than that, it also complements recent advancement in bedside ultrasound. So meaning that we can we can calculate the RPP using ultrasound. So instead of palpation and visual using our eyes, we can also use ultrasound to demarcate where the edema starts and where the edema ends. So, and it has also been shown in recent studies that using ultrasound and RPP has improved or has helped clinicians in the management of snake bites. Okay, so overall, we are moving away from visual estimates. RPP is a better and more standardized parameter to monitor patients in snakebite envenomation. So the strengths of this study is that this is the first study to systematically quantify the proximal progression in Malaysian Naja bites, and it provides evidence-based management for copper bite in Malaysia. So unfortunately, there are some limitations to this study because the patients were recruited from a database. It may not reflect all cobra cases in Malaysia. The RPP that was collected may be susceptible to observer bias because this was not done in only one hospital. And the small sample size for intubated patients. So that's why maybe the pre-antivenom RPP was not the odds ratio for the pre-antivenom RPP for intubation was not statistically significant. But overall, in conclusion, we found out that RPP gauges envenomation severity, it predicts antivenom therapy, and monitors for treatment success or failure. So in the future, we suggest that a prospective multi-center study to be done to validate RPP against systemic outcome markers. So take-home message. So rate of proximal progression or RPP provides a quantitative, standardized alternative to traditional subjective visual estimates, enabling precise pre- and post-treatment monitoring. So a patient comes to you, it's very important for us to initiate the measurement of RPP early to catch those patients who may benefit from antivenom therapy. And after you've administered your treatment, which is antivenom, it is also very important to monitor the RPP post antivenom to see whether your treatment is successful or not. Okay, number two, an accelerating pre-antivenom RPP is a powerful independent predictor for initial antivenom administration, as mentioned before, highly associated with an odds ratio of 42 after adjustment for potential confounders. So if you see a patient with an accelerating pre-antivenom RPP, always be vigilant because these patients may require antivenom administration. Number three, an increasing pain score trend and the presence of comorbidities also strongly indicate the need for antivenom therapy. As I mentioned before, pain score goes hand in hand with an accelerating pre-antivenom RPP as well. And those with comorbidities, we need to keep an eye on these patients very closely because they have a high risk of developing severe envenomation and they have high risk of developing complications. Number four, post-antivenom RPP serves as a practical tool for monitoring treatment success or failure. So after you've administered your antivenom, always measures the RPP post-antivenom. Because if you just you leave the patient like that, you will never know whether your treatment is successful or not. Number one. Number two, you need a way to monitor whether the patient requires additional antivenom doses because some patients may require more than just one dose. Okay. And last but not least, while RPP is an excellent gauge for local envenomation, clinicians must remain observant for systemic neurotoxic signs. So even though we have we found out that RPP is very useful in initiating the antivenom. We always need to be mindful of systemic science, which sometimes may not be reflected on the local science, right? So basically what I'm trying to say is that don't just hone on the RPP. Always look at the patient situation as a whole, right? Because we know that cobra bites causes local and systemic inflammation, right? Okay, so these are my references, and with that, I thank you.
Thank you very much, Dr. Akmal, for that insightful presentation. Just a gentle reminder to our participants, if you have any arising questions directed to Dr. Akmal, please post it in our Q&A chat box. And he will address your question, respond to your question during our Q&A sessions later. Okay, without further ado, we will continue with our second session of the day. Ladies and gentlemen, it's my pleasure to introduce our next speaker, Dr. Hartadi Tanjoyo. Dr. Hartadi is an emergency medicine specialist currently serving at Dr. Saiful Anwar General Hospital and Hermina Hospital in Indonesia. He completed his emergency medicine specialist training at University Brawijaya with distinction, followed by years of frontline experience in emergency medicine. His clinical interests include trauma care, emergency ultrasound, management of critically ill patients, and toxicology. He is also a committed person to a continuous professional development, include advanced training in toxicology. Today, Dr. Hartadi will be sharing his expertise with us on the topic Airway Compromise Secondary to Green Viper Bites in Cultural Performing Artists. Please join me in giving a warm welcome to Dr. Hartadi.
Yes, hello. Thank you, Dr. Baratan. Okay, I will directly start my presentation. Before we can see this video first, yeah. This is our culture, our traditional culture. We call it pantengan dance. Yeah, we call it pantengan. The people wearing the full mask or banteng. Yeah. Pantengan dance in Indonesia is known for its mystical and spiritual atmosphere. Yeah. So the people usually eat chicken, or maybe in the video the people eat snake. Yeah. But it also may influence on the audience also. The audience frequently fainting and become entranced and hypnotized during the performance due to the spiritual energy. This is our case. Children are 14 years old boy developed severe swelling on his face, lip, and inside his mouth. It got so bad when he started having trouble at breathing, and he came to hospital. The swelling happened after he was bitten by a snake. His boy R had planned to perform bantengan by biting the live snake with his mouth, part of the ritual. But things went wrong. From the inside his mouth, the snake bitten bite, striking right on the buccal area and piercing through the cheek, like in the picture. And then how we manage the patient? When the arrival, the blood pressure is 141 over 93, heart rate is 94, and respiratory rate is tachypnea 26 times per minute, and saturation oxygen is still normal, and temperature is still normal. We should concern with immediate rate airway potentially compromised, and we prepare for rapid sequence intubation directly. This is how we manage the patient. First, we prepare for intubation with RSI, and the second, for Venom neutralization, we give polyvalent antivenom. We give one vial in 100 cc NS over 20 minutes, along with tetacam 215 unit for tetanus prophylaxis. And finally, we also give differential anaphylaxis. So we give dexamethasone 10 milligram and we give fluid loading 500 cc. Yeah. And then we can see the upper graph when the patient came, the platelet still normal, but on the 5th day, the platelet decelerating to 106. It indicated the patient had coagulopathy or maybe like consumptive coagulopathy. And below the RPTT is increasing on the day 2, but come back to normal on the day 6. Yeah, maybe in the day 2 the coagulation has start perform, so the RPTT is increased. This is from the blood gas. Yeah, it show acidemia. The acidemia is might be came from lactic acidosis with addition of high carbon monoxide retention, maybe because of ventilator settings. And then this is the lung or the chest X-ray is normal X-ray, yeah, when we follow patient, but we should cautious about IRDS or maybe fluid overload. And then this is the urinalysis. There is a blood in the urine with erythrocyte dysmorphic, but the renal is still intact and has a normal renal function. From the electrolyte, we found the patient initially had hypokalemia and then rebound to rapid hyperkalemia. And then we correct the hyperkalemia and the kalium is stabilized. Urine output is still yellow, it's not hemorrhagic, it's not red or macroscopic red urine. From the outcome, the patient is extubated on the day 7, and then on the day 10, the patient is discharged. And this is the discussion. When we found the patient, we should make sure that is that the right green fiber. We can see the green fiber that is very venomous in this picture. Yeah, we call it Trimesaurus albolabris Indonesia, and the others we also have Trimeresaurus insularis. It has vertical pupil and it also has pit, so we call it a pit viper, and it also has a red tail. Similar with these people, the people often misnown, yeah, with ular pucuk or aetula or ular gadung. These two snake is not really venomous, or maybe it's a mild venomous snake. Usually the symptom is local and also self-limiting. So we do not need antivenom. Nah, this is what I found in the journal, in the internet, in Malaysia, in Pahang, yeah. They reported a case, about similar case, yeah, with a biting viper bite on the left cheek in this patient, yeah. This is the patient before and this is after patient discharge, yeah. And surprisingly, we manage the patient almost the same. This is the enzyme that have role in viper envenomation. We should separate as two reaction. First is local tissue reaction. With the enzyme is metalloproteinase, phospholipase A2, and collagenase. These three enzymes can lead to severe complications such as blister anachromasis. Maybe they will lead to compartment syndrome, skin necrotic, and also digital gangrene. Phospholipids A2, this is a green pit venom that doesn't remain localized because phospholipids toxin actively lyses cell membranes upon subcutaneous injection. Continuous lysis creates spreading chemical burn under the skin and allowing massive fluid shift, run away, make a retinal edema, and slowly, maybe later, can develop to cellulitis. Such in this case, the facial swelling is not merely an inflammatory response, it is the active mechanical destruction of tissue boundaries, allowing venom tractability down the facial planes. And we should also don't forget with the systemic reaction that may be caused because of serine protease and also C-lectin and integrins. Serine protease contain thrombin-like enzyme that make fibrinogen consumption and fibrinogen syndrome. This will explain the coagulopathy or consumptive coagulopathy for the patient that bitten by green snake. And then the C-tablectine will promote lateral aggregation and then lower the thrombocyte count. This is our systematic approach to green pit fiber local envenomation. We should assess for anatomical red flag, where is the part of the body that bitten by the snake. If the snake bit the area facial, we should assess neck involvement, especially when the involvement is split to region 2 or maybe region 3, moreover. We should give intubation early, like in this patient. From the patient in the Malaysia before, they delayed the intubation until maybe like more than 12 hours. So the patient already snake and it's hard to intubate the patient and it will lead to tracheostomy later. So better we intubate the patient early. And then we should also focus on the local symptom like a compartment syndrome, and we can perform wound care, especially when there is necrosis and blisters, and then we give antitetanus. So it is interesting how we give the antivenom, because in Indonesia antivenom is very limited and antivenom is very costly and expensive. For simple local edema, we usually do not give antivenom because there is no clinical significance and there is a anaphylactic risk from the antivenom. And the second, for the progressive and severe swelling, there is still debatable. But in this case, we give the antivenom because the swelling is involving the second region on the neck. It will lead to the compression of the trachea. And also maybe there is a compartment syndrome or increasing in the RPP like Dr. Omar presented before. And the last and the most important is usually we give antivenom is systemic indication, especially where there is systemic bleeding like GI bleeding, epistaxis, hemorrhagic stroke, etc. And then thrombocytopenia when the platelet count drops below 100,000, and then there is a mixed coagulopathy when maybe no coagulation on WBCT more than 20 minutes or INR elevation more than 1.2. This is the antivenom that we give. Is similar with this from Thailand, but our availability is very limited. This is when the swelling involving zone 2, we should give intubation and we should concern more of the airway obstruction. This is the illustration of the airway obstruction when the larynx becomes swelling. This is from my patient. The swelling is involved until region 3, and this is the bite chick. So what we should focus. We should anticipating for obstruction. Yeah, we should concern that mechanical obstruction is more important than coagulopathy. When the classic crimping venom, uh, it will lead to hemorrhagic. Yeah, we should concern with thrombocytopenia, the whole blood clot more than 20 minutes and systematic breathing. But in this case, in the facial bed profile, we should concern about the airway first, and then we manage the systemic or the bleeding. So the clinical framework, yeah, we should concern from the airway and breathing and circulation first. So rescue the breathing, and then we neutralize the venom. We keep the ASV, and then we secure. Maybe we can use focus to track subclinical edema, as Dr. Omar presented before. Yeah, this is my reference. Yes, thank you for the time and the presentation.
Thank you very much, Dr. Hartadi, for the insightful sharing and excellent presentation. Okay, once again, dear participants, if you have any rising questions, kindly post your question in our Q&A chat box, then it will be answered respectively during our Q&A session by our respective speakers. Okay, we will now take a 15-minute short break and resume our seminar at, so we will take a rest now. So 15 minutes, so we will join back here at 9:45 so that we can continue with our next session of the day. So kindly, I'd like to remind all the participants to return promptly at 9:45 so that they can proceed with our agenda of the day and to ensure the flow of our sessions. Thank you very much. See you again at 9:45. Welcome back and once again everyone. I hope everyone is refreshed and ready for our final session of today's seminar. Okay, with us today, it's my pleasure to introduce our distinguished speaker, Dr. Jonathan Maratas Paghubasan, an emergency medicine specialist and training officer of Eastern Visayas Medical Center in Tacloban City, Philippines. Dr. Jonathan has extensive experience in emergency medicine and is a fellow of Philippine Board of Emergency Medicine. His professional interests include emergency medicine education and training, point of care ultrasounds, toxicology, sanitation, and emergency care. He is also actively involved in residency training, development of assessment tool, research monitoring, and various emergency training programs. We are truly honored to have him with us today, and we look forward to learning from his experience and his topic today will be on Envenomation challenges in Archipelago, a review of Snakebites and Toxins in Eastern Visayas, Philippines. Ladies and gentlemen, please join me in welcoming Dr. Jordan.
Hello, good morning, everyone. So it's nice to be here in this session in the emergency medicine seminar series. So allow me to share my slides. So again, I will be discussing the envenomation challenges in an archipelago, particularly in our country here in the Philippines. So a review of snake bites and marine toxins in the Eastern Visayas, Philippines. So let me start with this quote. Like a snake sheds its skin, we are capable of getting rid of assembled habits and creating space to call matters into question. Way back before, I can recall that there was no much interest on envenomation here in the Philippines. And I can say that relatively in the Philippines, toxinology is quite young in terms of its age of interest. But nevertheless, as years goes by, particularly with the establishment of various toxicology centers in the country, there was now growing interest. And now we are getting to know more of the toxinology status in our country and trying to address this gap in our healthcare system. So let me start with a disclaimer. So this presentation is prepared and delivered solely for the academic and educational and research purposes. And the content reflects the scholarly work and interpretations of the authors of various research that will be featured here and does not constitute official institutional policies or professional practice guidance. The authors declared no conflict of interest, financial or otherwise, related to the material presented today. So let me summarize our objectives for my presentation. To first, clearly appraise the current landscape and systemic challenges of envenomation management in the Philippines through the lens of a recent advancement in regional toxinology, with particular emphasis on to analyze the epidemiological data and trends of envenomation cases, specifically with the Eastern Visayas region, or the Region 8 of the Philippines, and also differentiate the multifaceted challenges encountered in envenomation management from both public health, infrastructure, and bed clinical perspective, and also evaluate translational research progress, therapeutic innovations, and evidence-based updates in clinical toxinology. Let me proceed. So let me have a review of the components of our ecosystem here in the region, in the Philippines. So the Philippines have 7,641 islands, and with 300,000 square kilometers, with a population of currently 14 million. It is divided into 18 regions, 82 provinces, and 149 cities, with 1,493 municipalities and 42,011 barangays. Of this 42,000, there is unidentified 10,875 as geographically isolated and disadvantaged areas, or those areas that are not easy to access. In my region, the Eastern Visayas region, or the Region 8, there are 18 municipalities that are considered geographically isolated, with 1,300 barangay communities. In total, my region has 4,625,929 population. In terms of our healthcare system in our region, we have 6 major provincial hospitals that caters the 6 provinces in the whole region. Of these provincial hospitals have all 100-bed capacities. In each province, it has 11 general district hospitals, which approximately have 50 beds. In spite of this, we still have the current hospital bed to population ratio is still at lower, very far from the reality as expected from the World Health Organization, which is 25 to 30 per 10,000 population. Currently, what we have is 2.8 beds per 100,000 population. And all of these community facilities, or the provincial hospitals, are level 1. When we say level 1, these are the basic tier of general hospital. It provides essential emergency treatment and minor surgical capabilities for both illnesses and injuries, and acting as a first point of inpatient referral within the healthcare network. Also, in our locality, there is the antivenom is only available in 7 community hospitals. But then again, there is very limited manpower or personnel that are capable in administering the antivenom or assessing envenomation among our patients. Given the antivenom available in the country, the generally accepted is the purified cobra antivenom, a monovalent liquid form, and also given our demographic in our region, cold chain logistic is a nightmare to begin with. And there is also a very poor referral process or coordination among these hospitals into our tertiary hospital. This results now to patients seeking alternative healing as an option to their envenomations. So this is where our major provincial hospitals are located, and subsequent general hospitals. So in terms of the unique, the toxin profile in the region, in terms of terrestrial threats, in the Philippines, there's a prevalence of the Philippine cobra, or the Naja philippinensis, the Samar cobra, or the Naja samarensis, and the equatorial spitting cobra, or the Naja sumatrana, with additional of the king cobra, or the Ophiophagus hana, and vipers such as Trimerosaurus flammomaculatus and Tropidolaemus sabunalatus in the land. But in our region, the most predominant is the Naja samarensis, and the Opipagosana, and all these vipers, or the Trimerosaurus clavumaculatus and Tropidilaimus sabunalatus. In terms of marine threats, on the other hand, there was the predominant presence of box jellyfish, particularly the Chironix flickeri, which is involved with most cases of envenomations in our locality. Recently also, we have recorded incidents of cone snails envenomation, particularly exposure to Conus textile and Geographicus. There were also recorded cases of branded sea crate exposures and envenomation, and also increasing number of encounter with stonefish and stingrays. In terms of our epidemiological data, so what we have here is the epidemiological data that we have recorded for the past year since 2018. Why 2018? Because that's when the poison center gets established in our region. You can see here, the predominant cases still is a snake bite encounter with more than 100 per year, and with more than 100 per year, with notable mortalities more than 1%. Actually, in reality, for the whole country, the Eastern Visayas region is one of the top 3 regions with most cases of snake bite, and also the top 1 in terms of mortality. Maybe this is because we have very limited access to antivenom, and we have very poor understanding of the snake presence in our locality. We have also notable number of cases of marine envenomation, especially the jellyfish, which we have recorded mortalities in the past years. Also, the stonefish, the conch snails, stingrays, and various insects such as scorpions, centipedes, and spiders. Next slides. Next slide, please. So to address our envenomation cases here in the region, we have established the healthcare provider network and referral system. In the Philippines, the healthcare provider network is an integrated group of primary, secondary, and tertiary facilities organized under the Universal Healthcare Law. The primary goal of the healthcare provider network is to eliminate the highly fragmented nature of the Philippine healthcare system, and it connects public and private health entities so that patients experience a seamless continuum of care rather than navigating a confusing medical maze on their own. In this healthcare provider network, there is what we call the service delivery network. Here, that is where the problem comes in terms of referral system. There was a gap between the primary care facilities and to the Apex Hospital. Because in the Apex Hospital, that is where most of the antivenom is located, yet the primary care facilities have disconnect in terms of referring patients to our facility. Maybe because there was delay on the recognition of envenomation from these snake bites, or the delay of manpower that is capable to administer or assess the patient. So there was a break between a patient bitten in the peripheries in the rural areas as compared those within the nearest to the cities. Furthermore, there is no standardized protocol currently in the country with regards to management of envenomation. And this now poses a problem among healthcare providers in the country as to what protocol to follow when dealing with forms of envenomation. Next slide. So what are our challenges? First is the monovalent constraint. We still rely on the purified cobra antivenom as the monovalent liquid form of antivenom present in the country. Although there was not much study conducted on its applicability on other forms of snake envenomation in the country. There is a lack of efficacy against other regional species like vipers or absence of antivenom to marine envenomation, but not limited to box jellyfish. Increasing the production of the antivenom and development of new one is a resource-consuming intervention. With less support from the government and the private sector, achieving complete protection from envenomation is still a great challenge to overcome. Currently, we are testing under compassionate use a polyvalent antivenom, lyophilized antivenom, the Tarado, which is still on, again, as I have said, on compassionate use, which is now applicable to envenomation from the Naja philippinensis, Naja samarensis, and Archipelago sana. Another challenge that we have is the stocking dilemma. The purified cobra antivenom and also the Tarado are expensive in relation to the daily income of a rural inhabitant, making purchasing a challenge. This, coupled by logistical limitations, our archipelagic demographics, and the strict cold chain for the pickup, coupled the cold chain requirement of the pickup, the high cost, strict cold chain storage requirements, and expiration risks of keeping antivenom stocks at low volume, remote municipal hospitals versus the centralized risk of keeping them only in major cities. So those are major challenge with storing on the two antivenom we have. Also, the role of supportive care. When antivenom is unavailable due to archipelagic delays or lack of supply, high-quality supportive care such as mechanical ventilation for neurotoxic respiratory failure or intensive wound management for necrotic viper bites, though a lifesaver, is inadequate if not absent in the remote hospitals. Even the management for advanced airway is still lacking in our primary hospitals. Most of our patients that arrives in our tertiary hospitals arrives in dead on arrival due to asphyxiation because no personnel is capable from the referring facilities of securing the airway of these patients. Next slide. So these challenges results to the reliance of the patients to alternative healings. What we have here in predominant is the tando or the albulario first response. This is resulted from limited access and deeply ingrained cultural reliance on traditional healers who practice suction, stone applications, or herbal poultices. This drastically delays seeking standard medical care until systemic envenomation is well advanced. This was well documented among our patients from the provinces, wherein most of the patients would prefer to seek traditional healers before seeking medical care. Also, the occupational vulnerability. There are limited evidence-based profiling of most risk population, predominantly rice farmers in the Samar Leyte Plains and artisanal fishermen, and the economic impact of envenomation on these breadwinners. This may result to limited assistance and support to the program of envenomation management. Biological documentation of snake and marine species along their venom composition understanding have increased in the last decade. Collaboration with various state universities and non-government organizations have helped increase interest in snake and marine species mapping, but much research on venomics are to be conducted in partnership with foreign individuals, institutions, either alone or in partnership with Philippine counterparts. Currently, we have very limited research undertaken locally on venomics, and there are very limited meaningful studies on the clinical aspect of envenomation as well as its management, such as antivenom, supportive treatment, and alternatives. Next slide. So currently, what we are following, since we don't have a standardized envenomation management protocol, in the previous years, we've been opting to use these two type of protocols. One from the Research Institute of Tropical Medicine, which is an adaptation of World Health Organization protocol for snakebite in Southeast Asia. And we have also the National Poison Management and Control Center from the Philippine General Hospital. If you can see here in this protocol, they differ in terms of the number of antivenom to be administered, but both of them advocates the use of neostigmine. Also, uh, they both agree that there was no need of giving an diphenhydramine and hydrocortisone, which was the previous practice way years before. But I've suggested also observation for 24 hours at least. And also they differ in terms of dilution. So this kind of protocol has been developed by independent institution. This one is a government research institution. This one is a university-based hospital. And they don't usually agree much on the number of dosing of antivenom. Next slide. To harmonize everything, various stakeholders of envenomation conducted a meeting and started the SALAG initiative, or the Snake Action Logistic and Antivenom Group in the Philippines. Here since we don't have yet a protocol or a guideline, we rather adapted in the meantime an algorithm, treatment algorithm, an approach to snakebite envenomations. Here we consolidated the findings from both from the Research Institute of Tropical Medicine as well as from the National Poison Control and Management Center, as well as from literatures from various World Health Organization, and integrated this one protocol. In this algorithm, we can see here that the approach to snakebite envenomation was categorized between neurologic, hematotoxic, cytotoxic, and for those with no envenomation. And the treatment options here were also included to include both the two types of antivenom that we have from the purified cobra antivenom, as well as from the polyvalent lyophilized antivenom, the Taradoc. We also incorporated here the use of neostigmine as an alternative in the absence of antivenom. Now, where did we base this algorithm? Since there is very limited literature currently on the use of those antivenoms and neostigmine in treatment of envenomation, we don't have much local studies, observational, prospective, or interventional studies on the effects of this antivenom to our patients as of currently. So we base this on the following research. Next slide. In the last 2025, the Naga University, in partnership with the Eastern Visayas Medical Center, conducted a multi-year prospective research to observe the characteristics of snakebite cases in our region. Next slide. Previous slide. By the way, previous. So in this study, it showed there that the high number of cases were observed in September, November, and April, almost contrary to the natural cases of exposure from Naja species, because most encounters in other countries are recorded from the months of March up to May. While in the Philippines, there was a recorded increase of cases from the months of September to November, and as well as April. So there was no clear seasonality or association observed with precipitation. So in December, there was a relatively high number of probable Naja samarensis cases than of improbable. So that gives this research unique picture of the pattern of envenomation from the Naja samarensis, which is more particular in our locality. Also, there was documented in this research that there was predominant presence of localized skin necrosis observed as compared to the bite from the Naja philippinensis, which most commonly with no visible signs on their bite site. So that's one thing that we observed to differentiate the Naja samarensis envenomation with the Naja philippinensis because the Naja samarensis tends to have localized dermonecrosis. On the other hand, the Naja philippinensis don't manifest such kind of presentation. Also, the incidence of bite from the Naja samarensis for the past years have been at home, and most common victims are students, run contrary to the other literatures that shows that most exposures are in the farm or involving farmers. So this is quite a unique information that maybe there was an increasing migration of these snakes among communities in our localities because the exposures nowadays are predominantly within households. Next slide. In the use of neostigmine also, this was taken from the research in the Northern Mindanao Medical Center about retrospective study of patients treated from envenomation. Due to the limited supplies of antivenom in the country, and since this antivenom, the Philippine Cobra antivenom, was really intended for the Naja philippinensis, we don't get much a supply from the Manila since what the predominant species in our localities in the Eastern Visayas and the Mindanao is the Naja samarensis. So what we get is just a portion of the supply. So due to this limitation, we have been mixing, especially here in the study in the Northern Mindanao, mixing neostigmine as an adjunct therapy. But it showed promising outcome. So here in moderate and severe envenomation were effectively managed, fully reversing envenomation symptoms with reduced antivenom doses of up to 1 to 5 ampules, contrary to the established guidelines recommending higher doses. So there was a literature conducted last 2023 that analyzed the venom of Naja samarensis and the action of the purified cobra antivenom in vitro, which showed there that there was little activity or it would require more antivenom doses. Here in this study, it runs contrary to the requirement of antivenom clinically. Also, in this study, it showed that neostigmine as an adjunct to the presence of PCAB can lower the dose requirements. That's why we are also putting as an option neostigmine or an first alternative in the absence of an antivenom. Next slide. Also, we have known, since we don't have yet concluded much research clinically, what we have most are case reports documenting various characteristic and features of envenomations from Ophiupagus hana and the Naja samarensis, which are predominant in our locality. Here we have documented that for the Naja samarensis envenomation, it is also likely associated with cardiac complications. This one is a case of a 71-year-old male bitten with a Naja samarensis and presenting at the ED with an SVT. And the patient was treated with the purified cobra antivenom. You can see 2 ampules only because of the very limited availability of antivenom. And if you can see in the picture also, the bite marks features a localized dermonecrosis, which we cannot see from the Naja philippinensis bites. Next slide. This one also are the 2 remaining cases which features cardiac manifestation. One from the case 2 is a 50-year-old female presenting at the ED after snake bite with Naja samarensis and presenting with a STEMI. The patient was treated with neostigmine with 0.6 atropine followed by 1.2 milligram neostigmine, which resolves the neurotoxic envenomation. But eventually, the patient was discharged. And the other one is a case of a six-year-old male bitten with a Naja samarensis, but treated with a polyvalent lyophilized antivenom or the Taradoc. But this one uh, died along the way because of the refractory uh, supraventricular tachycardia. So this case report showed that the possibility of cardiac complications among the Naja samarensis in Envenomation. Next slide. Also, a case report that we have done is from a probable king cobra or the Archipelago species envenomation resulting to cardiopulmonary arrest. So here in this case, there was sequential antivenom escalation. A 50-year-old female initially treated with the purified cobra antivenom with very minimal effect, then sequentially treated with the antivenom polyvalent lyophilized antivenom, which now resulted to return of spontaneous circulation and gradual improvement of the Glasgow Coma Scale until full recovery with subsequent discharge after 7 days admission without deficit. So this patient arrived dead on arrival, actually with ongoing resuscitation and administration of initial is the purified cobra antivenom. Then subsequently, since there was no effect, the patient was given with the Taradoc or the polyvalent cobra antivenom. The patient had return of spontaneous circulation and eventually regain of the motor and improvement of Glasgow Coma Scale. So this was a possibility of escalation between the use of cobra antivenom, purified cobra antivenom, and the polyvalent lyophilized cobra antivenom. Next slide. Also, we have reported cases of venom ophthalmia from the Samar cobra. This is the first case of documented localized exposure, cytotoxic exposure of the Naja samarensis envenomation in the eye, which featured localized the ulcerations on the cornea. You can see here in the picture that the cornea is positive for abrasions, corneal abrasions. But this patient didn't develop systemic envenomation. A case in the northern Mindanao wherein the patient was exposed to spitting cobra, hitting his eye, but manifesting rather with systemic manifestation. This one didn't have systemic manifestation, but more on of a local cytotoxic envenomation. Next slide. To further connect the gap with our challenges here in the regions, to further understand our toxinology cases here, and also to explore other options, since we cannot resort to developing antivenom immediately and currently, we conducted further trying to explore traditional remedies in the community, which is ongoing right now in collaboration with the Nagasaki University as well as the Visayas State University. The research titled Factors Associated with Delayed Hospital Visit for Snakebite in the Eastern Visayas, the Philippines, and Exploring Traditional Remedies in the Communities by Yoshihiro Aoki. Also, we have an ongoing study with the development of a PCR diagnostic assay for snake envenomation in rural health facilities of Eastern Visayas. This is a multi-center prospective study and diagnostic utility. In this study, we try to utilize or develop a PCR-based identification of snake species causing the snake bite. This in hope that we can identify and sort patients, those that would require immediate management versus for those without envenomation. So in this study, we have established a DNA sequence for Naja samarensis, Naja philippinensis, and Ophiophagus hana as well as vipers and viper species, as well as non-venomous snakes as controls. And we have already piloted this one in other facilities, which proved positive outcomes of identifying DNA on bite marks, on bite site rather. So we're going to roll out this one now this year to collect specimen if we can sort patients and hopefully assess whether this technological innovation would be practical and useful in our setting, especially for the bites concerning bites that in the rural areas. Also, to fully understand the antivenom effects of the purified cobra antivenom as well as neostigmine and the polyvalent lyophilized antivenom or the Taradoc, we are conducting right now a clinical outcome of patients study with Naja Species Envenomation treated with the purified cobra antivenom. This will become a multi-center prospective and observational and will serve as a basis for indication of the use of the purified cobra antivenom for the Naja Species. Because currently right now, the indication for the purified cobra antivenom is for the Naja philippinensis. But we've been using it already for a couple of years now for the Naja Samarensis as well. But again, with very limited or no evidence on its effects and side effects, as well as therapeutic doses. Currently also, we're trying to address the gap of the referring system in our country as well as availability of antivenom by formulating a action plan project research wherein there is the bridging the gap, evaluating halfway medical stations or facilities utilizing neostigmine to improve rural health, rural snake envenomation survival and recovery, an action plan and project. So in this kind of research, we're trying to identify hospitals within an hour ride from the most community and training their personnel in assessing envenomation and using neostigmine as an adjunct or temporary relief prior to the definitive management or transport to facilities with definitive availability of antivenom. So this research is ongoing right now for the protocol development to check if this will become effective alternative since we cannot stock antivenom in our rural facilities, nor they have the capacity to handle them, the antivenom. So right now, it's more easy and practical to use neostigmine. So we're rolling this out this year to our partner communities. Next slides. So these are the interest areas for improvement in the envenomation management in our country. There was inadequate prospective clinical research to understand deeper the effects of envenomation among population and antivenom treatments. There is no the standardization of the first-line protocols to mainstream envenomation management and judicious use of limited antivenom supplies. So that's why right now we still adopt the algorithm treatment consensus from various toxicologists and toxinologist experts in our country until we have a more meaningful clinical research that will prove the dosing, the severity, the dosing of antivenom to each snake envenomation. Also enhancing referral and service delivery network to shorten time to definitive treatment and maximize resource allocations. With this, we are trying to identify facilities that are within an hour's ride from each community for us to empower with regards to manpower, skills in management of envenomation, airway, securing airway, as well as assessing envenomation and the initial treatment with neostigmine. Also exploring more strategies to access to evidence-based treatment through the use of informatics and digital platforms. The Philippine government right now is exploring ties in developing snake identification applications similar with other countries, particularly in Australia. At least with this, if they can upload a picture, there would be an attempt to identify the species, but still this is on development. Also, enhancing skills and knowledge on management of envenomation with mainstream treatment modalities, as well as the alternatives and supportive ones. Envenomation management has been increasingly, has interest on the envenomation management has been increasing in the past years, but still this is not part of the core competence of every medical practitioner in the country. So we're hoping to incorporate this one in our academic formation for our physicians, as well as establishing further courses to enhance their skills in management of envenomation, as well as the supportive and alternative treatments. I think that's it, and thank you.
Thank you so much, Dr. Jonathan. It's been a very eye-opening insight on the challenges that you are facing in your localities. So thank you again to Dr. Jonathan for the presentation. Okay, so with that, ladies and gentlemen, we have come to an end of our 3 lectures for today. So next we'll be going to our Q&A session. But before we step into our Q&A session, we would like to take a short break, about 10 minutes. Welcome back to everyone. So next we will be going into the most awaited Q&A sessions. So those who are still have any question that you want to ask can still post the question in our Q&A chat box, and we will read and try to answer, discuss the topics and the question with our speakers as much as we can. Okay, so in the Q&A session box, so the first question is to Dr. Akmal. Okay, so to Dr. Akmal, in patients who already have cellulitis, how do we differentiate the baseline cellulitis from new local tissue changes from a snake bite, particularly for assessing the RPP?
All right. Actually, a very good question. So sometimes when a patient who has already have some form of edema on the lower limb, whether it be from a pre-existing lymphedema or an ongoing cellulitis, sometimes it's quite difficult to differentiate. But we know that if you have an acute injection of the venom due to the snake bite, there will be progression. So what you need to know is that, number one, you need to monitor, still need to monitor RPV, because cellulitis does not progress proximally rapidly, right? And number two is that there will be an increasing amount of pain. So pain is also a very important factor to monitor when you have a patient in these patients. Okay, so yeah, I would say that you monitor the RPP, but at the same time you also monitor the other clinical aspects. For example, the pain score and also the presence of dermonecrosis, for example, in cobra bites.
Thank you, Dr. Amal. So, participants, so I hope that answered your questions. Before that, I would like to invite all our speakers to open your video so that we can have a more engaging sessions after this. Welcome back, Dr. Jonathan and Dr. Hartadi. So, next question is also directed to Dr. Akmal. So, how long did you observe patient for RPP? Is it enough for 3 hours or 3 hours of consecutive?
Okay, so in my study, we observed, we took a minimum of 6 consecutive readings of the RPP. What does that mean? So you could either at a minimum observe the patients for 6 hours because you want to get 6 readings, but sometimes you may also get that 6 readings within more than 6 hours. For example, sometimes, due to limitations, you are unable to monitor the patients hourly. So you may, certain people, they monitor it, for example, they take the reading every 2 hours, for example. So but you still need to at least have a minimum of 6 readings. So in my opinion, so I don't think 3 hours is enough. So you need at least minimum 6 readings. So that means at least a minimum of 6 hours to monitor these patients. Okay, unless the patient comes in with no clinical signs at all. For example, there's no pain, there was no edema at all, there was no dermocrosis. So in those cases, you may be able to consider a shorter period of observation, but in patients with clinical signs of local envenomation, for example, pain and erythema and edema, you at least need to monitor them for a minimum of 6 hours and get at least a minimum of 6 readings of RPP.
Yeah. Can you hear, Doctor?
Yes, yes. Now,
so there's a question which was directed to you just now, but in the Q&A session, but it was asking about which ASC was administered to this patient. But I'm not really sure which patient in specific which our participant mentioning lah. So anything that you want to comment on that question, Doctor?
okay, maybe I want to clarify. We give the patient with hematopolyvalent antivenom because we do not have green pit hypervenom, green pit vipers antivenom in my place. Yeah.
Okay.
The dosage is under dose. We know that the dose from the manufacturer is about 3 vials at the first dose, and the second maybe you can edit another 3 vials. Yeah, but in my case, I just give 1 vial and the first dose, and 12 hours later, 24 hours later, I give another second dose only one vials also. So overall is underdose because that's all we have here. Thank you.
Thank you, Dr. Okay, there's a question which was directed to Dr. Jonathan, but he already answered it in the Q&A session lah. But I'll just read out the question. If Dr. Jonathan want to explain more about it, you are welcome, Doctor. So basically, there's a question asking about what is the difference between the use of appropriate antivenom and the use of neostigmine. Do we still need to use an antivenom if we have neostigmine? Do you have anything else to elaborate on that, Doctor?
Actually, in our setting, due to the very limited antivenom that we have, we try to save as much as possible antivenom. So we start with the minimum antivenom, the 2 vials antivenom for severe envenomation. Because of most facilities that we have here only have 2 vials at most. That is only to bridge for the transport. Then subsequently, as an alternative, that's when we used neostigmine as an alternative adjunct therapy, which showed promising result. It resolves the neurotoxic envenomation of the patient. So based on our initial research here conducted in the 2 facilities from the Northern Mindanao Medical Center as well as here the Eastern Visayas Medical Center, in the absence of antivenom, we opted to use pure neostigmine all throughout. The only problem that we encounter is there is a frequent dosing at least every 4 hours for the next 72 hours with closed monitoring because there was a high chances of recurrence of neurotoxicity or the envenomation. In the other hand, once coupled with the purified cobra antivenom, there was a shortened period of treatment of neostigmine. So, like for example, when we use 2 vials of antivenom and subsequently use neostigmine, we have observed a reduced hospital stay of up to only 2 days. So again, it depends now on the case-to-case basis here because there is not much wide clinical research done on the combination of this treatment. There's only done retrospectively among records of our patients here in the 2 facilities. That's why currently we are trying to conduct more in-depth research understanding on patients treated with neostigmine, if it can be used as an alternative, pure alternative to antivenom, basing on its cost effectiveness, availability as well. But initial findings that we have, it is really promising and beneficial for the patients using pure neostigmine in the absence of antivenom.
Thank you, Dr. Jonathan. Okay, we go back to our first presenter, Dr. Akmal. Dr. Akmal, there's a question which was asked to you. The questions as I had a patient who was bitten by Naja species. We proceed with antivenom in view of accelerating RPP and pain score. After antivenom, there is no reduce in pain score, but there is a static RPP. Patient require few doses of morphine for pain management. In this case, will you suggest for second dose of antivenom in view of a persistent pain? Thank you.
Okay, so in this case, you need to understand what does static RPP means. So sometimes RPP can be cruising, meaning that it's still progressing but at a static rate. For example, it's just it's just progressing at 1 centimeter per hour consecutively. So this is what we call cruising. Other measures is, for example, it could be, if you're referring to static, meaning it stops there, then there's going to be a different thing. So for example, if the patient is still complaining of pain and the RPP is still cruising, meaning that it is static at 1 centimeter per hour, but it's still progressing proximally, so then these patients will require antivenom. Because in my study, we divide those patients post-antivenom RPP as 2 categories, a non-decelerating and a decelerating RPP. Decelerating means it reduces from, for example, 3 cm per hour to 2 cm per hour to 1 cm per hour, or the RPP stops there and there. The non-decelerating means it could be either accelerating or it could be cruising. So it depends, but always go back to your other clinical signs and symptoms as well. For example, in this patient still complains of pain, and the pain did not reduce. So that means there is still ongoing tissue injury. So I would say that in these patients, you may administer a second dose of antivenom.
Thank you, Dr. Akmal. Next question asked there in our chat box. There's a question regarding the ASV. The ASV which was given, this question was directed to Dr. Hartadi lah. But okay, Dr. Hartadi. So basically the question sounds like the ASV given is HPAV or GPAP. So the treatment is lower than usual dosage, right? Because the vial is limited. How about coagulopathy outcome post antivenom? How many total vial is required? And did he redevelop the re-envenomation syndrome? How long for the facial and airway swelling to subside after the airway administration? So they just ask for how the progress of the patient after that, doctor.
Okay, thank you. For the patient, for the airway is, I think it's result about 7 days. Yeah, so the patient the TCS improved for six about approximately third day in the third day. So after that we can accept the patient, and the swelling also improved. Yeah, because of that. With coagulopathy profile, we do not much examine the profile. So the last time we examined the profile is on the 6th day, which is the result is quite good. I think the PT and APTT is normal, yeah, INR is normal, but the thrombocyte is still drop, yeah, in 100,000 cell per year per milli. And then yeah, so after then we move the patient to regular ward, and we observe clinically there is no improvement of swelling, and also there is no sign of another bleeding, and then we discharge the patient on the 10th day. Yeah. That's the answer. I hope it will clarify the doubt. Thank you.
Thank you, Dr. Hartadi. Okay, so there's a question. Okay, for the next question, so I will open this question to all our 3 speakers. So if we already have a reading of 2 hours of 2 centimeter per hour RPP, do we still need to wait for another hour before administering antivenom for the local envenomation? So any idea, anything that you want to explain, or I open the question to all 3 of our speakers?
Okay, I think I can try to answer that question. So, reading of 2 hours of 2 centimeter per hour, what does that mean? Yeah, so you're saying that the RPP is 2 cm for the first hour and 2 cm on the second hour. So this, again, RPP for me is a trend. So you want to look at the trend, whether it's accelerating or not. So if 2 cm per hour for 2 consecutive hours is still considered cruising, it's not accelerating. So you still need to continue your observation and trend the RPP, because maybe when you trend the 3rd hour, it could be reducing. So then it could mean that the RPP is decelerating. So in my study, the patients who have accelerating RPP have shown to have an increased odds to receive the first dose of antivenom. So, and then we took the at least a minimum of 6 readings, but if there are 3 consecutive readings showing accelerating trend, then we administer the antivenom was administered. So in my opinion, you have still need to continue monitoring to see the trend and not just the pure number of the RPP. Okay.
Thank you, Dr. Akmal. Dr. Hartadi, anything to share on this question?
Yes, I mean, I want to share in our place, yeah, with our condition. Maybe I a little bit disagree with the slide before Dr. Omar presented, yeah, about the value or the cost in our country is much higher than Malaysia, because in reality, the antivenom is very expensive, and we cannot afford it. Very limited also. So in the reality, we cannot afford when the patient is progressive RPP or maybe have more bitten limb or maybe locally swelling on the local side only, on the limb only. Maybe we do not give the antivenom, yeah, because based on RPP. But I know I want to give the antivenom, but we do not have the luxury in my country or in my place. Uh, so yeah, usually the antivenom is reserved for the, yeah, first when the antivenom is readily available, and the second when the usually I and my team is consult to Dr. Tri Maharani, specialist emergency. Yeah. After she decide and give permission to us, yeah, we can, so the antivenom will be sent and we can use the antivenom. Yeah, and usually it need a more of systemic symptoms, such as like mungkin maybe like ptosis or paralytic from the elapid bites, and the fibroid is hematologic abnormalities with also with the bleeding symptoms. Yeah. Thank you.
Thank you, Doctor. There's another interesting question in our chat box regarding focus. So as an emergency department team, so focus will be our main use of our everyday life lah. So using focus, when to start monitoring in these cases of envenomation, when do we start monitoring swelling using the focus? Any ideas or any experience regarding the using of focus in the monitoring of the swelling from our speakers?
Okay, I think I can chip in that question. So, using the usage of point of care ultrasound is, as I mentioned before, is a very good complement to your bedside assessment, because ultrasound can delineate the area of edema more accurately. Okay. Actually, there's a protocol that you can use, which is called the PULSE protocol, which is spelled as POLES. So, or we call it, it's the focus for local envenomation from snakebite. So you can actually use this protocol. And if you have the ultrasound, so it is better to use it as soon as possible, because in comparison to your visual estimate, point of care ultrasound or ultrasound itself is more accurate in determining the presence of edema and the demarcation area. So if you can, it is better to use point of care ultrasound. But of course, not all hospitals or not all EDs have point of care ultrasound. So you can still use your traditional way of measuring the RPP. But if you have ultrasound, I would suggest to use ultrasound.
Thank you, Dr. Akmal. Any input regarding the use of ultrasound or focus from Dr. Jonathan?
Actually, with regards to the swelling, we try to monitor them immediately as soon as possible of the incidence of the bite. And we usually use marking, but with the advent of the ultrasonography, we use ultrasound as an adjunct for the assessing, is particularly for the progression for a possible compartment syndrome. We look for on the cobblestone presentation in there instead of the more invasive one using the injection. So as early on, we try to document it as early as the patient arrived on the hospital, or at least every 4 to 6 hours eventually, noticing the progression not only of the swelling but also the presentation of the tissues in the ultrasonographic imaging to look for possible compartment syndrome. So as early on, so that we can at least estimate the progression, since we don't have any antivenom for neurotoxic, cytotoxic effects and hemotoxic effects. We are also under study right now the use of hemoperfusion as alternative to removing the venom for cytotoxic and hemotoxic envenomation. So if we can see that there was already progression of the swelling as well as the possible increasing and susceptibility to compartment syndrome, we now subject the patient for hemoperfusion, in which we have already conducted for a couple of patients, which proved promising as well in lessening the swelling as well as relieving the envenomation.
Thank you, Dr. Jonathan. Okay, I think we still have a bit more time, so we'll go for another two questions. This question is actually regarding the cases of green pig vipers over the face. So the questions was the decision making and also multidisciplinary approach. So the question was, in the outside, swelling over the face indicate local envenomation as mentioned. So prior to intubation, does it warrant for us to defer the case or involve our ENT colleagues prior to intubation? Is it indicated and is it useful, and does it bring a better outcome for the patient? And number two is that if during our intubation there's no any local swelling over the internal airway or our pharynx region, so does it still warrant for intubation or not?
Okay, thank you. Maybe I will answer with my opinion. Yeah, first, in my place also, we do not involve the ENT, but we rather use the video laryngoscope. Yeah. It's very helpful, and yeah, fortunately also there is no swelling in the airway, such as before. But in the case from the Malaysia that I mentioned before, there is involvement with ENT also for tracheostomy after for 12 hours. Yeah, if I'm not mistaken, from the case for in the Malaysia in Bahang before. But in my case, we just use video laryngoscope and the patient has not undergo tracheostomy. But maybe our length of stay is much longer, yeah, than in Malaysia. In Malaysia, the patient stay about 4 days, but in my place is about 7 days in the ICU with intubation. Thank you.
Thank you, Dr. Hartadi. So last but not least, so there's a question was given to Dr. Jonathan, but I'll still open the question to anyone else to want to answer the question. So basically, Dr. Jonathan, how long will you monitor the patient with only neostigmine treatment? As you mentioned before, the localities the problem with the localities and the challenges that you're having in your localities. So how long will you monitor the patient with only neostigmine treatment in your center? And will you transfer the patient to a tertiary center or just monitor the patient? And how you justify that the neostigmine solely treatment failed, thus requiring the antivenom? How you go for the next step after the neostigmine?
So usually in our setting, because not all the time we have the antivenom, we always stuck with the neostigmine. And based on our local protocol here, we observe the patient after 24 hours. So there would be a continuous administration or maintenance of neostigmine for the first 24 hours. After the first 24 hours, we relax that one to observe for recurrence of neurotoxicity. Should there be recurrence, we continue it another 24 hours, then continue observing it after 24 hours further or 48 hours. So in short, we treat the patient continuously. After, for example, there's an envenomation, we treated with neostigmine and there was remission of the symptoms. We maintain the patient every 6 hours of neostigmine of a dose not more than 10 milligrams in 24 hours. After 24 hours, we relax the administration of neostigmine to observe for the recurrence of neurotoxicity. And if there's none, we continue observing the patient for the next 72 hours, up to 5 days, then subsequent discharge. But should there be recurrence after 6 hours, we administer again neostigmine. Now, with regards to the alternative of antivenom, we usually, since we have very limited antivenom, and most facilities only have 2 to 4 vials per patients. The current World Health Organization guidelines on the administration of antivenom suggest for severe envenomation, it should be at least 5 vials, which already very below the available stocks in every facility. So usually we give that 4 vials initial dose, then observe the patient for remission of the symptoms. But should the neurotoxicity recurs, we now use neostigmine and followed again what I have said as previously, that every 6 hours maintenance, then relax after 24 hours for evaluation for recurrence. And if there is none, we just monitor the patient for at least 72 hours.
Understand, Doctor. Okay, so next, regarding, because we've been talking about antivenom administration mostly is by IVs and IVs and all. So there is a question they're asking about is there any role for a local administration of antivenom, either IM or subcutaneous, in reducing the swelling in cases of envenomation. So any experience in using a local antivenoms in your cases or in your centers from our speakers?
Well, in our setting here, we really don't advocate local administration of the antivenom, since then again, the venom injection in the body is through the lymphatic system. It does not stay on the tissues actually. So we have observed no benefit, especially in viper bites or in the localized toxic effects of samarensis with regards to the administration of antivenom on the tissues. So we didn't observe any benefit on that. That's why we refrain from giving that, because it's just a waste of our resources. But without prejudice of possible upcoming research or possible other antivenoms that can be administered locally. But in our setting, the purified cobra antivenom, we have observed no benefit on local toxicity. So that's why we don't advocate giving it in the local bite site.
Understand, Doctor. So so another question regarding to Dr. Jonathan. Because just now when we was talking about the focus, you have mentioned about the hemoperfusion. So there's a question directed to you. They are asking about how does hemoperfusion reduce the swelling caused by the local envenomation?
Uh, it was conducted initially from research. I forgot that the venom molecule of cytotoxic from a viper are quite large as compared with the other molecules. So it was then proposed that the hemoperfusions can filter the venom from the blood, reducing now the spread of the venom in the local area. So we have already conducted trials here, and at least we've served already around 2 or 3 patients, and we have observed that the swelling reduced dramatically after 2 sessions. But in order to really resolve the swelling, we observed that the patient can consume up to 10 hemoperfusion sessions. So we're still actually understanding deeply on how is it going, but we have identified it's more on the removal of the actual large molecule based venom. So of course, if you can remove the venom in the blood that is causing the cytotoxic and hemotoxic effect, then definitely the necrosis and the swelling will be decreased. But then again, it's not quite it's quite expensive actually. Every session that we have cost around 35,000 pesos. So computed into 10 sessions, that would be around 350,000. So we reserve that one already as an adjunct or alternative for extensive cytotoxic and hemotoxicity for viper envenomation.
Understand, Doctor. Thank you. So yeah, it's limited by the resources that we have. It will always be there. Okay,
Yeah.
Dr. Hartadi. Okay, Dr. Hartadi, there's a question regarding one of the the presented case just now about the species that bite the patient. So our participant was asking whether it is a verified or unidentified snake bite, and how does the decision of antivenom administration at that time was made. Is it basically they're asking whether that they are decided based on the swelling itself, or is there any other factors that help you to make a decision on when to administer the antivenom in that cases?
Okay, yes, thank you. At first, the species is exactly a green pit viper, but we do not differentiate what is the what species from the green pit viper genus. Yeah. Usually, in the literature, we saw that in my country have two most popular green pit viper. The one is Chimeresaurus insularis, and is usually in the middle of our Indonesia, like Nusa Tenggara, Bali, in that region. And our region is similar to Malaysia, maybe. We have Trimeresaurus albolabris that we often found in Java Island or maybe Sumatra Island or some of Kalimantan Island. We have Trimeresaurus albolabris. And for indication, as I mentioned before, there is if usually there is a mild envenomation, we do not give the antivenom. But in this my case is local envenomation, but life threatening on the dangerous area. So we give immediately we give the antivenom. Actually, there is many research and many uh, debatable opinion when to give antivenom also. I hear in India it start give antivenom immediately in an hour after the patient admitted in the ER, and also maybe in Malaysia already start intramuscular or subcutaneous injection antivenom with REX recommendation. I think, yeah. So, but in my place, yeah, we give depend on the severity. And also for the flow, we should consult first to our ministry, tepat in from the person in charge in the ministry, from her to give antivenom to us. If she approve, yeah, we can give the antivenom as soon as possible. Like that. Thank you.
Thank you, Dr. Hartadi. So I apologize, Dr. Jonathan. There's another question directed to you. So there's a question asking regarding any preclinical studies done for the efficacy of a Taradoc antivenom. So it appeared the manufacturing was in India. So that's the antivenom raised from the venom from a local species or from the Philippines or from India. So they're asking about the source of the antivenom of the antivenom, and does it applicably in use in your localities?
Actually, with regards to the polyvalent lyophilized antivenom, what we have learned about its production involves an Indian company, the BioNTech company. But we have identified the species collection of the snakes involved in the production were from the Philippines. So actually, that's a controversy actually because I think that it is prohibited in our law to be capturing wildlife and transporting it outside. But then again, what they did is they collected the venom instead. There was a venom harvest done way back years ago from the local species in the country. And it was initially tested in one province here in our country for a couple of months. But then again, there was this resurgence or the increase of demand of antivenom. That's why, due to the because during that time, around 2022, our production for the purified cobra antivenom has dramatically decreased because of some problems with the technology and the animals and the horses. So there was no, our government was left with no choice but to use the Taradoc under compassionate use. So it was given to the facility the choice to use the Taradoc as an alternative antivenom in the absence of the purified cobra antivenom. So until now, we use it under compassionate use because it's not done yet with its research. So it's still on the clinical efficacy and safety. But we are already conducting research from multi centers using the Taradoc, and we've been observing multiple side effects, such as those with anaphylactic shocks and some cardiac manifestations as well. So that's why a lot actually of our facilities are hesitant in using the Taradoc unless it is the only one left available. So that's how we identified and how the Taradoc has been produced. So it was produced in India from venom coming from our country. So the snakes has been left in our country, but the venom for study was extracted and harvested and transported to India.
Thank you, Doctor. So basically, it's all the matter of locality and availabilities. Okay. With that, I think we answered most of the questions which was asked and projected by our participants. Here, I would like to take this opportunity to invite each of one of our speakers to give an note, to give a take-home message to our participants. I think we will start with Dr. Akmal.
Okay, so at the end of the day, in my presentation, I was talking about RPP, but you should always you should not rely on RPP alone when you are managing cobra bites, because you always need to take the patient as a whole, because patients who were bitten by cobras, they may exhibit local and systemic inflammation. So sometimes, even though the RPP does not show an accelerating trend, patient may still have systemic toxicity. So always look at the patient as a whole. Always look closely for the signs and symptoms of systemic toxicity, and do not rely on RPP alone when you are monitoring patients with cobra envenomation.
Okay, thank you, Dr. Akmal. There's some errors in my video. I apologize for that. Next, we go to Dr. Jonathan. We would like to hear about your input on an input and take-home message to our participants.
Well, as for me, I believe that we in the Southeast Asia, and most of our countries are working in a resource limited situation. So I think we should be open to exploring alternatives to antivenom, because we know that antivenom is quite expensive. We are very uh, we are very interested with how Thailand produce a lot of antivenoms, and actually our government is collaborating to procuring some for them, for those. But then again, for us who are working in a resource limited situation, we also have to explore alternatives such as the possibility of using neostigmine, probably edroponium, in addressing neurotoxicity, also hemoperfusion, also for envenomation and systemic localized cytotoxic envenomation. And more on that, we have also to identify to bridge the gaps among our patients, especially from the bite side up to the reaching to the hospitals, because most of the patients problem actually because of the delay of the seeking of care. So I think still much to be done on the pre-hospital setting of managing envenomation, and maybe some innovations on how to deal with envenomation in a remote and pre-hospital setting. So I think we have to also look into that to increase the survivability among our patients. Thank you.
Thank you, Dr. Jonathan. Last but not least, Dr. Hartadi.
Yes, thank you. For me, take-home message is first, we should secure the airway, breathing, and circulation first. Yeah, especially when there is life-threatening life-threatening local inflammation. Maybe usually we overlook for systemic inflammation and make it more important than local inflammation, but not in all the case. Yeah, especially like in my case, is local inflammation is more important than systematic inflammation. And the second, yeah, maybe like in our country, yeah, we in my place actually, we do not depend on the antivenom usual antivenom like maybe like Dr. Jonathan was said before, because there is a research also that we have been my resident have been inducted that that mentioned, usually local envenomation is mild and non-life-threatening with good prognostic outcome. Yeah. So maybe that's all for me. Thank you.
Thank you, Dr. Hartadi. So what we can learn is actually it been a problem. So basically locality and availability will always be a problem in managing envenomation in our patient. So through maybe perhaps through our collaboration with our committees and our sponsors and also our committees, we can come with a more better solution, preparation and guidelines in order to improve our overall patient survivability. So thank you very much to all our speakers for our excellent discussion and for taking time to answer and address all the questions and the queries that our participants have. With that, we would like to conclude our Q&A session for today. A huge appreciation to all our speakers for sharing their expertise and knowledge with us today. Once again, our sincere thanks to Dr. Mohammad Akmal Omar, Dr. Jonathan, and Dr. Hartadi for their valuable insights and contribution to make our today's seminar a success. Thank you so much.
Thank you as well.
Thank you very much.
Okay, so dear participants, so we will now move to our final session of our seminar today. But before that, just give us a moment, about 5 minutes, to us prepare for our Kahoot session. So while waiting, you can enjoy the video of our promo videos given by our sponsors and organizers while waiting for us.
Man, it feels good to finally be off the shift rotation and out in the real wild.
Something bit me!
Don't move, let me clear the area. We have a suspected pit viper bite in the Mossy Forest Trail, requesting medical evacuation.
Copy that. Stay calm, coordinates received, help is en route. Professor, I have a case of suspected pit viper bite with systemic and local envenomation.
Which region in Malaysia did this occur?
We have a severe pesticide poisoning here! Send the toxicologist! Diver presented with severe decompression sickness, requesting for hyperbaric oxygen therapy. We are miles out from the trailhead. We need an extraction team!
Join the region's premier emergency medicine series.
Okay, now let's see who's our top 3 winner. Number 3 is H2O. Number 2 is SV. And number 1, yeah. Okay, so we are pleased to announce that these are our 3 top winners for today's Kahoot session. Which will each receive a lifetime access to an EM Stat apps, proudly sponsored by our EM Stat. Ladies and gentlemen, we have now come to the end of our week 2 of the 8th Emergency Medicine Seminar Series. On behalf of the organizing committee, we would like to express our sincere appreciation to all our distinguished speakers for sharing their expertise, knowledge, and valuable contribution to making our today's seminar a success. It has been an honor to have all of you with us today. We will also like to extend our appreciation to our organizer, University Kebangsaan Malaysia, University Brawijaya, and University of Philippines, our co-organizer, Toxicology Education Resources and Development, and in collaboration and our collaborators, Southeast Asia Remote Envenomation Consultancy Service, College of Emergency Physicians Special Interest Group in Clinical Toxinology, Malaysian Society on Toxinology, Malaysian Society of Toxicology, Philippine Toxinology Society Incorporated, Toxinology Society of Indonesia, Wilderness and Austere Medicine Society, Pusat Racun Negara, and Malaysia Biodiversity Information System. And of course, a very special thank you to all our participants for your active participation and engagement throughout the seminar. We hope that today's session have been beneficial and the knowledge shared will be contribute toward improving our approach or to the management of our patients. Again, we look forward. We'll be looking forward to welcoming you again to the next week, which will be the 3rd week of our 8th emergency medicine seminar series, with more exciting topics and discussions. Thank you again. Have a wonderful day and see you next week.